we have those situations where we get the patient back. You've been in the code for 30 minutes, 45 minutes, and you get the pulse back. Everyone high fives and scurries out of the room. But I'd make the argument that even though it seems like the hardest work has been done, the hardest work for that patient is yet to come. Because what happens when you get that pulse back is that there's a high chance that that person is going to slip back into cardiac arrest. And everything we have to do has to ensure that that patient stays with a pulse. And then we want to make sure that that patient gets back home with intact neurologic survival. So that's what this lecture is going to be focused on. I like to look at post-ROSC care as a bundle of 3 different boxes. And I break this up into the first 15 minutes, the next 45 minutes, and then ICU type stuff. The first 15 minutes is that period of time where you get the pulse back and you know that there's a high degree that that person could go back in cardiac arrest. So our goal is to push that patient forward, stabilize them, and make sure that they don't arrest. The next period is the next 45 minutes, and in that period of time, we want to make sure that we're doing some fine-tuning details. And the last little bit is going to be the ICU level stuff, where if you work in a department that patients go upstairs quick, that's great. But most of us work in places where the patient stays downstairs. And so you can't take your foot off the gas in the care of that patient. You're going to have to do some stuff that they might do upstairs. But again, it's all for neurologic intact survival. So let's talk about the first 15 minutes here. Again, that's the period we want to prevent the patient from arresting. So right after we get the pulse back, I'm going to do a couple of things. Now, if you have an arterial line in during the code, that's great. You can use that to continue to monitor the patient. If you don't have the A line in, you can't get one in, or you're waiting to get it set up, I want you to cycle that cuff every 1 to 2 minutes. The reason why is because that blood cycle monitor is default to 10 or 15 minutes. And that patient might be slowly decompensating, and you won't know until someone makes the observation, cycles the cuff, and notices that there's 0/0. Cycle that cuff every 1 to 2 minutes. And if you see the person's blood pressure slowly starting to decline, it's giving an indication that you need to get back to that person, think about what things you're missing, and get aggressive with their care again. I personally like to have end-tidal set up for this patient, and I think most modern-day emergency rooms should have this because you're not using it for respirations per se, you're using it for cardiac output. And if you have somebody who gets return spontaneous circulation, you'll see that their end-tidal is high, maybe it's 50 or 60. But as you start to go on and that end-tidal starts to drop, gets to 30, gets to 20, it's telling me that their cardiac output is dropping. And if their cardiac output is dropping, that tells me that they're at a higher risk for rearrest, and I got to get back to that person and see what we're missing and make sure they don't slip back into cardiac arrest. The last bit, the nurses don't really like me for this one, but I'll tend to put the pulse oximeter into the auditory setting, that thing that you always hear like anesthesia in the OR, that beep, beep, beep. Because as I'm doing procedures on the patient, putting in the A line or doing the ultrasound, I want to listen to that person's pulse and listen for the tone and the frequency. As that's changing, it tells me that I need to look up at the monitor and pay attention to my patient. Because again, everyone's left the room. Everyone's happy that the person got a pulse. And it might be just myself or one other person in that room. I want to know what's going on with that patient when I take my eyes off the monitor. The next step is obvious for most people, but I think it's very important that we remember to look for ischemia aggressively, get that ECG, look for a STEMI. I also am very aggressive. I want to look for STEMI equivalent. I want to get a cardiologist on the phone one way or another. Now, I know we had the talks from yesterday and today talking about, the Tomahawk and COAC trial, and maybe we don't need to call them. I call them anyway, and I engage them early. If not for catheterization, in some places, they're the gatekeepers for mechanical support. They're the people who are going to be giving the yes or no for ECMO or Impella or intraaortic balloon pumps, something that's going to support cardiogenic shock, and we'll talk about that a little later. But I like them to know about the case early on, even if they're not going to come in. And then finally, one ECG begets another ECG. It's part of my bundle of care to keep getting EKGs to look for more data. And I've talked about this before, and other people have as well. Ultrasound is going to be very important for me. The ultrasound that we did intra-arrest, as we spoke about yesterday, is just to look for reversible causes. Now, once I get the pulse back, now's the time I'm going to take my time and slowly examine the patient. Maybe now that sliver that I didn't really think it was an effusion, maybe it's pericardial tamponade because I got a better look at this heart. Maybe I didn't have a chance to look at the chest. Maybe we didn't get a good look at the heart. Maybe now I see this parasternal short axis view here in cardiogenic shock. This is telling me that this person whose pulse is low, whose blood pressure is low, I might need to get cardiology to come in, or critical care, or who's ever doing ECMO to come and address this low cardiac output. We take a look at this chest here. We have a hemothorax. Maybe the person coded because of hypovolemia, but I got a good look at the chest now. I was able to make a better assessment of this person. So having access to ultrasound and doing a good exam afterwards is very important. Also, doing a physical exam after getting ROSC is important. And I know what you might be saying. It's like, yeah, we all do physical exams. I'm talking about making sure that this arrest wasn't due to something else. I've had countless cases, as I'm sure you have as well, where the person comes in and looks like they're a cardiac arrest from an ischemic cause or hypoxemic cause, and maybe there's a bullet wound that's missed, or a stab wound that's missed, or there's some trauma that you didn't see. Being sure to roll the patient over, look in the axilla, look in the groin, look in the perineum, make sure that you're not missing anything at all. And then finally, getting a good history on the patient. This means getting on the phone with the family, having EMS stay at the bedside so that you can get a detailed history. What exactly led to the arrest? What were the patient's symptoms, days to hours before they arrested? Getting some more information so that you're not boxed into this is just, oh, this is an ischemic type of cardiac arrest. There may be something else to it. I don't discriminate when it comes to labs. We're getting lots of labs. I pay attention to things like the lactate, not so much the initial lactate, but I want to see that it's clearing. You may have ABG pluses, I call them, or an ABG with shock panel. This is something that's a point of care test where you get your gases back quickly, and you'll get things like electrolytes, creatinine, maybe a hemoglobin back. These are just quick tests that are not as accurate as your lab tests, but give you a better idea if there's something you might have missed as you got ROSC back on the patient. If I don't have a good reason for the person to arrest, I'll send some tox stuff. I'll send acetaminophen. I'll send salicylates. I'll send alcohol levels, because sometimes there are situations where the cardiac arrest was preceded by a toxic overdose. And what I'll do often is I'll get cultures. I won't necessarily send them, but I'll hold them to the side, because if I get on phone with the family and they say, yeah, they've been sick, they haven't been eating well, they've been febrile home, maybe the person was hypotensive from sepsis and that led to cardiac arrest, and then I can send those cultures off. But I like to have that bundle already drawn and ready to go as my initial pass during lines and insertions and whatnot. All right, let's talk a little bit about medications here. Vasopressors, if you had the person on epiboluses or a dirty epi drip, now's the time to transition the person over to a formal drip, ones that mix up by the pharmacy, one that you could accurately administer in the pump. If the person got lidocaine or amiodarone, now's the time to transition them over to the continuous infusion of those drugs. And a very important point is never to forget analgesia and sedation. Just because the person in front of you is not moving or wincing or biting the tube or swatting you away doesn't mean the person is aware. Go with something hemodynamically stable like a fentanyl or hydromorphone for your patient, and then if they need additional sedation, then provide that as well. But just because the person's not conscious in front of you doesn't mean they're not aware. I put airway at the last part of this 15 minutes, even though a lot of people want to get that extraglottic airway or supraglottic airway out and intubate the patient, because if it's working, if that initial airway management tool is working, why go ahead and change it? Why get distracted by taking out the tube? All the things we just talked about are far more important to keeping that patient hemodynamically stable to avoid them from losing their pulse. This is the last thing I want to do, is mess with the airway. Once we have all that other stuff done, by all means, swap out that tube and swap out that iGel or whatever you have in place, and then put in a formal endotracheal tube. But until then, I don't see a need to mess with the airway. And the final part of this 15-minute bundle, this first part of resuscitate and stabilize, is to debrief the team. You might be saying, there's lots more things to do. I don't have time. I'll debrief the team later. The fact of the matter is, you likely work in a very busy emergency department, and there's never a good time to debrief the team. So I always take 5 minutes to pull the team out of the room and just say, listen, what did we do well? What could we do better? Who had any thoughts about how the code went? More than likely, that's all you're going to be able to get to on your shift. And if you get to more later, then great, add on to it. But I make it a habit of mine to make sure we do this 5 minutes of debriefing. So if department explodes and we can't get back to this debriefing, at least they got this time with me and the team to discuss. So that's my first 15-minute bundle. The next 45-minute bundle is a lot of fine-tuning stuff. Okay, so we stabilize the patient. We're pretty sure the person's not going to rearrest. Let's go through some of the things that we have to be cognizant of to make sure that the patient has the best survival. The first thing is to go back to the ventilator. By now, you should have gotten an ABG back, and you can look at the settings. Maybe you shouted out, a respiratory rate of 14, tidal volume at 500, PEEPA 5, whatever it is that you normally out. Now's the time to look at the blood gas and go back and get to a tidal volume that's consistent with ideal body weight. That's 6 to 8 cc's that we always talk about. Make sure that you're avoiding hyperoxia. The literature is kind of mixed on this. There's some literature that used to say that hyperoxia is worse for patient outcomes. There's some that says maybe it's not so bad. I would always err on the side of giving the patient the least amount of oxygen possible, the part that's safe, because too much oxygen can cause free oxygen radical formation, and that could lead to injury of reperfused tissues. So until I see a great study that says that that's absolutely not true, I'm always going to try to get the FiO2 down to as low as I possibly can. The PaCO2 is also important. If you have too low PaCO2, what happens is the person is going to vasoconstrict. And if it's the PaCO2 is too high, they're going to vasodilate. This causes problems with intracranial pressures. So you just want to get it right. Go for like 40, 45, 50 at the most. You want to be somewhere in the range so that there's not too much vasoconstriction. We don't want to be hyperperfuse the brain, and we don't want them to be vasodilated where there's an increase in intracranial pressure. And then finally, this is the cheapest intervention you can do, is just elevate the head of the bed 45 degrees after you finish assessing your patient, because this is going to decrease your risk of ventilator-associated pneumonia. Imagine you did all this work, this patient did well, and now they get a secondary hit of ventilator-associated pneumonia when they're in the ICU from laying flat. So just elevate that bed 30 degrees. Let's talk a little bit about access and lines. My first line, if it's not in already, is getting an arterial line. I want to know not only the blood pressure to titrate my vasopressors to, but I also want to know if the patient codes, now I have my pulse being palpated internally. We talked about that yesterday. Having that A line in is going to allow me to monitor that pulse when it's time for our rhythm check. So get that A line in first. Some of you might be saying, well, what about the central line? Shouldn't we get a central line in? Look, if you got an IO in during the code, for me, that's good even until they get up to the ICU. Now, if you're in a situation for that patient's getting multiple medications and they need more access, sure, then get in your multi-lumen catheters. But for me, the arterial line takes precedence over the central line. And then if you have time and the bandwidth, then you can go ahead and put in that central line after. It goes without saying, a Foley catheter is important, not only for the convenience of the patient, but also I want to monitor the patient's urine output. If the kidneys are putting out urine, that is a good sign that we're getting good, adequate organ perfusion. And then most of these Foley catheters come with thermistors, so you can monitor the patient's core temperature, because if you're going to be doing targeted temperature management, we're going to want that information. So be sure when you ask for Foley, it's one that has a thermometer. And most of the nurses will know this as part of their bundle of care already. We're going to go on and talk about MAP goals. It used to be thought that aiming for a higher MAP goal was better for patients, especially those who have chronic hypertension, better for their kidneys and all sorts of things. The fact of the matter is the box trial showed us that a MAP of 65 is probably just as good for anybody. So while you do want to individualize your care for each individual patient, a MAP goal of 65 is as perfectly fine as your target post-ROSC in your patients. When we talk about vasopressors, there's a lot of debate as to whether or not epi or norepinephrine should be used. You heard Scott yesterday talk about he runs a continuous infusion of 50 mics per minute of norepinephrine. That certainly makes sense. If you look at the literature, epi versus norepinephrine as a vasopressor, there's a higher degree of arrhythmias. There's a higher degree of worse neurologic outcome with epi compared to norepinephrine. So epi might not be the best vasopressor post-arrest for your patients. And that's why Scott and myself and others, we like to use norepinephrine as a vasopressor. So take that for what it is. If you want epi as an inotrope, then use in doses for inotropy. If you get to the point where you're having a patient now who's on one vasopressor, then two vasopressors, this would be a good time to take a look at the patient again. Take a look at that heart. The reason why is because maybe that patient has developed a degree of cardiogenic shock that might not have been evident before. And so you can give them vasopressors all day long and clamp them down, but if the heart isn't squeezing well, then you might have to shift strategies. Maybe it's time to add some low-dose epinephrine, or maybe it's time to add dobutamine. Maybe it's time to go ahead and ask for mechanical support, the intra-aortic balloon pump, the Impella, or VA ECMO. And this is why it's so important to get your cardiologist on board early. This is not a therapy that you can bring just with the snap of a fingers. This is something that's going to require mobilization of a multi-person team. So the earlier they know about that patient, the more they can start making some phone calls and letting the team know that there is a chance we have to come back to the hospital and place this patient on VA ECMO. So that's why I always get the cardiologists or whatever team is responsible for mechanical support involved early. The last thing we'll talk about is ICU stuff. And again, you might be saying, my patients zip right upstairs within 15 minutes. I don't have to worry about any of this stuff. Okay, great. For the rest of us, we'll have patients who are in the ED for a prolonged period of time, and we have to do certain things that are going to help that patient out. The first of which is to get EEG monitoring for the person who's unresponsive. This is something that's mandated in the AHA guidelines, and we're specifically looking for something called non-convulsive status epilepticus. Happens at a rate of 20-25%, depending on the literature you read, in patients who are unresponsive, ICU patients. And I want to know whether or not that person is having status, because their outcomes for non-convulsive versus convulsive status epilepticus is the same when untreated. So you're going to treat it as aggressively as you would status. Be sure that you identify which patients are at play. Now, you might be saying, well, it's impossible to get the EEG technician to come in. And that's true, even in large academic centers. But there are point-of-care devices that are available that will allow you to attach the monitor onto the patient, and the monitors will essentially read off to you whether or not the person is in status. And so these are great devices as screening tools to tell you whether or not that person who's unresponsive post-arrest is in fact a non-convulsive status epilepticus. Let's talk a little bit about some of the medications and adjustments. I'm going to speak very briefly about post-arrest antibiotics. There's very limited data, and most people would say it's pretty poor data about using antibiotics post-arrest. The thought behind this was it would decrease your ventilator-associated pneumonia. The data is not good on this. I personally don't use antibiotics post-arrest, but you may work in a center that wants this. So part of your bundle of care might be to continue antibiotics for this person post-arrest if that's what you do in your hospital, or if that's what your ICU consultant has told you to do. We already had Taryn talk about steroids, so I'm not going to belabor the point. But again, if they got steroids initially, this might be part of the bundle of care that you'll have to be cognizant of for the repeated doses in the emergency department. And then my pet peeve is IV fluids. This person got boluses of fluid. They got medications, they had everything running. We don't need to put this person on maintenance fluids. If this person is hypovolemic, they've gotten fluid resuscitated. And at this point, all you're doing is you're adding extra crystalloid to their interstitial space, which causes lots of harm in ICU patients. And it's really its own talk for a different day, but just chill with the maintenance fluids. Patients probably don't need it. All right, something that Brian talked about during the panel session was CT scans. Now, when it comes to CT scans, if you have a patient who's post-arrest and they're unstable, you'll have to make the decision whether or not you want to send this person to CT scan for a pan scan, or to send them to CT scan to just ask a specific question. I was always taught death begins in radiology. So the last thing I want to do is take this person who I just stabilized and now move them somewhere else in the hospital to do a pan scan. I will say that a trial just recently came out that says when you pan scan patients, you do find more injuries, but that didn't lead to any difference in survival to hospital discharge when compared to selective scanning. So where I stand on it is if I have somebody who I think might have a PE or intracranial bleed or some injury, I'll selectively scan that person earlier rather than later, because that will make a difference in the person's outcome. If the person had a very clear arrest based on history, based on everything I'm finding, then I'll wait for that person to get the CT scans and a pan CT scan on their way up to the ICU, because I'm probably not going to change my management, but there's going to be information that we want to know from that CT scan in order to manage them for the next few hours and next couple of days. So bottom line here is get the CTs that you think the patient needs. Don't rush your patient post-arrest over to get a pan CT scan when it's not indicated. I'm not going to spend any time because Brian did a good job on this, but where do we sit with targeted temperature management? At the end of the day, what I would do is I would talk to your ICU and neurointensivist and see what they're locally doing, what the guidelines are. Don't be that maverick in the hospital that says, I went to this conference, I saw what they said, and I'm going to do this. Because when they go up to the ICU, they're going to go ahead and do whatever protocols they want for the duration of the patient's care. So be familiar with the guidelines, talk to your consultants if they're available, and ask them what they prefer for this particular patient. And my final point here is when you have this patient and you're looking at them, try not to neuroprognosticate with the family about how this patient is going to do. Studies show that this is a very poor predictor. The physical exam is a very poor predictor of how the person is going to do. We really have to wait 72 to 96 hours to give a formal evaluation to the family. Now, I'm not saying be dishonest with the family. If the patient's seizing or they were down for 30 minutes before anyone found them, don't give them misinformation, but using things like the pupils are fixed or dilated, or the person had a seizure, avoid taking any of those and giving the family any neuroprognostic information because we just simply don't know. We have to wait for that patient to be cooled and then rewarmed and then a period of time before we can do any meaningful neuroprognostication. So be honest with families, but don't give them too much information until we have it. And so there you have it, the 3 buckets of care that I do for my patients post-arrest. The first 15 minutes is just to prevent them from re-arresting and getting unstable again. The next 45 minutes is doing the fine-tuning stuff, setting my patient up for their best neurologic survival and getting out of the hospital neurologically intact. And then finally, if you have patients that stay downstairs in your ICU, doing some things like the EEG, getting them cooled, and then CT scanning if necessary for your patients, because the longer you wait on those things, the worse out that person could be. So that's it for me today in terms of lectures. There's my social media handle. If you have any questions at all, please don't hesitate, or we could talk about it during the Q&A. But I definitely want to thank you for your attention and go back to Taryn.